So, now we are online. Welcome to this third webinar of the initiative Dentists United by WH. I'm sorry for this short delay, but we had the best case what one could wish for a webinar 3 minutes before we want to start. My internet connection completely collapsed, but it seems to be functioning now, so we can go ahead. As I said, this is the third webinar of a series of the initiative Dentists United by WH. In case you have missed the first two webinars, let me shortly introduce you what they have been about. The first one has been about a topic which has buffered us a lot in 2020. And I'm now not talking about sweatpants or about the toilet paper. I'm talking about the face masks, which have been literally going up and down, back and forward. So the topic of the first webinar was Repossessing Single-Use Face Masks, Yes But, by Kristina. And the second one was now recently in June by Professor Gassmann about aerosol in prophylaxis, a danger for the dental team. But today we would like to talk about getting back to business and whether we can also get back to do our surgeries. Before we start now with the webinar, let me shortly introduce myself to you. I've been studying dentistry at the Medical University of Vienna in Austria, and after that I have been working at the Department of Periodontology and Oral Surgery. But I have primarily focused on Periodontology. Since 2014, I'm working at the Department of Periodontology at the University in Malmö in Sweden. And why I'm working at the university? Because I love to do research, I love to treat patients and to educate the upcoming young colleagues. But now to the webinar. When WH asked me about a month ago whether I would like to give a webinar on COVID-19 or oral surgery, I have to be honest, I have been a bit skeptic in the beginning, because I'm now neither a specialist in hygiene or in biology. So I said to them, let me think 2 days about it. And then after those 2 days, we had a couple of discussions. And we think we have come up with quite some nice ideas, which we want to include in this webinar. And we hope that you're going to like them. So COVID-19 has been the main topic of 2020. But not only in our real life, also in research, this topic has increased tremendously. Let me give you an example. Mid of June, when I was allocated to this webinar, when I was typing dentistry and COVID-19 into PubMed. That was on the 19th of June. One had already, now I was a little bit too fast, let's go back once more. One could find already, just from the beginning of the year, more than 300 publications. And then, if one was checking that again, about 2 weeks later, beginning of July, the number of publications has increased by another 100 publications. Finally, yesterday, we have exceeded already 500 publications on the topic and more than 180 publications more just in the last month. So it really has a huge impact also on the research part of our life. But now to the webinar and to the topics which we have chosen and which we hope that you're going to like now in the next 45 minutes approximately. We would like to discuss with you a little bit how big is actually the risk of meeting a COVID-19 positive patient in our office. Where can I find information about the personal protective equipment and what are the current guidelines or recommendations on the personal protective equipment due to COVID-19? How can we maybe minimize the risk during surgery? Why shouldn't we skip the cooling during surgery? And the last topic, how long can we actually wait if we have done, for example, some augmentative procedures prior to the pandemic? How long can we wait now to get our patients back in to place, for example, the implant? Let's start with the first one, the risk of meeting a COVID-19 positive patient. I have made now some calculations based on Austria. On the one side, because I'm from Austria, and on the other side, because the headquarters of WHO are situated in Austria. And you can see them, let me show here. No, doesn't want to. Here's in Salzburg, in Burmos. So Austria has a population close to 9 million. And mid of June, they had about 440 active cases. So that corresponds to approximately 0.005% of the population. If we say now that we see approximately 30 patients per day, per working day, this results in a risk per working day to meet a COVID-19 positive patient of 0, then they come 5 times 0, 2%. Now, of course, that is difficult to imagine something, how big that actually is. So let me give you an example. The chance to guess the 6 correct ones in the lottery out of 45 are actually 3 times higher than this risk per working day to meet a COVID-19 positive patient at that time point in Austria. Or another example, how big is the risk to be struck by lightning in a whole lifetime? That is 0.033, which is 16,500 times bigger than meeting on one working day a COVID-19 positive patient. Of course, then one has to put a little bit in relation that the one is per working day, the other one is in a lifetime. But still, you get a little bit of a feeling how big the risk actually is. However, and now that is very important, depends a lot on the time and on the location and the country where we are working in, because the situations are quite different in our countries. So, for example, this was mid of June in Austria. If we look now at the numbers from yesterday in Austria, the numbers have been increasing again now in the last month. So we have now about 1,370 active cases. Of course, that is a little bit a bigger part of the population, and the risk per working day also increases approximately 2.5 and meets now approximately the risk of guessing the 6 correct ones in the lottery. But then we shouldn't forget, those 1,400 approximately are the ones which are registered, which are known that they are positive. Then we know that we have this big dark number of the unknown unknown cases. So how big is that approximately? If one looks, for example, at numbers from Germany, we know that the unknown rate is approximately twice of the known or registered cases. Or in Italy, they are guessing it's about even 6 times higher than of what is registered. So that we should always keep in mind if we make such calculations. And then, as I said, it depends a lot on the country where we are working in. Let me give you an overview about Europe. In Europe, that was 1 week in June, and this graphic is showing you the new infection rate per 100,000 inhabitants. And we can see that in Europe, most of the countries, except for Great Britain, Portugal and Sweden, are quite similar here. And they had only about 10 new infections per 100,000 inhabitants. Great Britain and Portugal are still quite okay, but they had up to 20 new infections per 100,000 inhabitants. And now, if we look at this long red line on the very top, Sweden, where I'm working in, here they had more than 70 new infections per 100,000 inhabitants. So the risk compared to the new infection rate compared to other European countries was more than 7 to 8 times higher in Sweden. And then if we go away from Europe, then we know that Europe is actually not the current hotspot of the COVID-19 pandemic. We have North and South America, which are contributing tremendously to the total number of more than 12 million infected people and to more than 500,000 of deaths due to COVID-19. Then, of course, one could say, okay, but they are contributing so much because they have a huge population. But if we look a little bit closer at this homepage from the WHO, then we can standardize the number per 1 million population. And then we can see that North and South America have the double rate of confirmed cases compared for example, to Europe. So it really depends a lot where we are working and how big the risk is for us as a dentist to meet a COVID-19 positive patient. And we should definitely not forget how much this pandemic has affected our whole population. Let me show you one slide from a webinar from Professor Hämmerle, which he has given for Geistlich sometime in May. And I have stolen one of his slides, because this slide is really impressive in showing how severe this pandemic has affected us. So what you can see here now on this slide is the blue lines are indicating per country the regular death rate in the last years. And the red line is indicating the death rate in 2020. And you can see here for almost all of the countries quite a huge peak now in the time March, April, May, most likely due to the COVID-19 pandemic. So that is really impressive. I can only recommend you to watch this whole webinar, which gives a lot of basic information. You have here the YouTube link if you're interested in it. Why is this now bothering us so much in dentistry? I think we all know why we are afraid about it and why we think so much about it. That is due to the aerosol producing procedures. And we can see here quite impressively by some videos which I got from WH how big the aerosol production is in our profession. You can see on the top the turbine, which is producing quite a lot. On the lower left, for example, the surgical handpiece, where we have, as one can see, a lower production of aerosols and most often a little bit bigger droplets. And on the right side, you can see the piezomet. And the problem is that we are doing all that in quite a close distance to our patients. And additionally, we know from quite an early publication in the New England Journal of Medicine that the SARS-CoV-2 virus is surviving a couple of hours in the aerosols. So here it is shown up to 3 hours and even longer on the various surfaces. And that is what is buffering us so much. But how much has it affected us now? Let me give you an example with an Italian publication. We all know how much Italy has been affected by this pandemic. What have they done? They have sent out a questionnaire to more than 9,000 dentists, and they asked about the symptoms and signs they have experienced, about the protective measures which have been taken, and in general about the awareness and perception of COVID-19. And they got around 3,600 answers, so quite a huge amount. Out of those 3,600, about 50% continued actually to work after February the 21st, so after the outbreak in Italy. And about 14% of those indicated that they have suffered one or more symptoms which could be referable to COVID-19. But of course, the symptoms like fatigue, for example, which is mostly the most often indicated symptom, is not quite specific. And that is now quite interesting for us and good to know actually. Less than 1% of those respondents was actually tested positive to SARS-CoV-2. And only half of them actually developed the disease. And those are positively surprising good news for us. And we have also heard similar low numbers from studies and publications from China. But of course, one has to keep in mind who is actually responding to such a questionnaire. Maybe not those which are right at the moment at the hospital or sick, but trying to recover. But still, the number seems relatively low. So what measurements have those dentists taken while they continue to work? So which measurements have been taken in more than 80% of the cases? That was washing of the hands before and after each procedure, what we should anyway do. A frequent ventilation of the waiting room and trying to make the schedule in a way that the waiting room is not getting too full. Verify the patient's health status after arrival, and prior to arrival the phone triage, and I will get there more in detail back later. And then frequent disinfections of various surfaces, of the push buttons, of the chairs, several times a day. Which measurements were taken by the dentists less often, so in less than 25% of the cases? That was actually measuring either the patient's body temperature or the body temperature of the team. And which rinsing solutions have they been using? That was in about half of the cases chlorhexidine, and in about every fourth case water peroxide. Now we know, of course, all the discussion that chlorhexidine seems not to be so efficient against this virus, and it is actually recommended to use primarily water peroxide or povidone iodine, or a combination of it. But for more details on that, I would like to refer you to the webinar of Professor Gassmann, who has addressed this topic in detail. And which personal protective equipment have those who responded to the question used now? Most of them, of course, have gloves and glasses, surgical masks and disposable headsets. For me, a bit surprising was the number of people using the FFP masks, because only every second was actually using an FFP mask. And quite a low number has actually used gowns. So with that, I'm already halfway into the next topic, the personal protective equipment before and after the COVID-19 pandemic. For this, I would gladly refer you to the AFP homepage. The AFP has made really nice infographics and recommendations on the personal protective equipment, which are free for everyone to download, and I will shortly also present them here to you. But we have to keep in mind, those are only recommendations and not guidelines, because guidelines are supposed to be based on science. And up to now, unfortunately, we do not have this evidence-based knowledge on that. So they're useful guidelines, useful recommendations, which can be considered in our daily practice. If you look now at those infographics, we can see one important thing is the phone triage. So if we are booking a patient, we should ask him whether he had symptoms, whether, of course, he was tested positive, whether he has been in a region which is known to have quite high numbers, or whether he had maybe contact to a COVID-19 positive patient. And depending on the answers, we either book or postpone the appointment of this patient. Then a very important point is the assessment of the patient's risk profile and needs. So how is it about the patient himself? And I will come back to that later in detail. And how important is the appointment that it's done right now? Or can it be maybe postponed for a while? And then, of course, as I said already before, we should organize the schedule in a way that the waiting room is not getting overfilled. What is now to do if the patients are arriving in our office? We can measure the temperature and send those homes with an increased temperature. The patient should remove the bags and the coats. We should provide the patients with hydroalcoholic solutions to disinfect their hands. We repeat the triage in the office. And if the triage is okay, we place the patient in the waiting room, which should be in best case ventilated, so with open windows, and at least 1 meter apart of the other patients. And if we want, we can also give them some shoe covers before they get or come in for the treatment. And then what I actually think is missing in this infographic is that we should let the patients rinse, as we said before, either with water peroxide or povidone iodine. And what should be done by the clinical staff? Of course, we should also disinfect our hands. We put on our gloves. We maybe put on a gown and a cap. We should use our FFP masks. We put on some additional goggles and maybe a second pair of gloves. How about the treatment itself now? Whenever possible, we should try to avoid aerosol production. So we should try to avoid those procedures. But we all know that that is not really realistic on the long term in a dental office. So what can we do if we have to do an aerosol producing procedure? We should use, as you see here with number 2, a high power suction. And I will come back to that also a little bit more in detail later on. Maybe we can use such shields, as you see here, which are covering the patient and thereby protecting us from the aerosols. Maybe we can use additionally some decontaminating sprays. We should ventilate in between the patients, the operating room, and of course we should disinfect all the surfaces. And I think that is quite important, and we all know if we are finally done with a procedure, we just want to get rid of the stuff. But then we should keep in mind to follow a specific way and a specific manner how we take off now all this personal protective equipment. So the technique doesn't like me so much today. No problem. I just jump here again. So here we are. So how does it look like now? We remove first the first pair of gloves and the gauze. We take off the mask, not the mask, the goggles or the face shields. And here we should always think that we should touch them as far back as possible and not in the front where we have all the aerosols, or because that is the part which is catching the aerosols. Take off the masks and the cap, take off the second pair of gloves, and then disinfect your hands. Here I can only recommend you also the homepage of the Center for Disease Control and Prevention, CDC, because they have also quite nice infographics and also videos about all those personal protective equipment. So if we think about how we have done previously simple controls or maybe fillings, we can see the personal protective equipment, which is recommended at the moment, has changed tremendously. It has changed maybe a little bit less for doing surgery, because there we have always been dressed up more. But we might need to think about the FFP masks, about the face shields or bigger goggles. Whether we need such an extensive equipment as we see it now all the time all over social media, we actually do not know. So we do not have any evidence-based knowledge on that, whether it is really required to dress up like that. So we can only stay to recommendations which we can find. The recommendations I've given you from the EFP, or you find them also on the homepage from WH, on the subsection Dentals United. You also find recommendations depending on which procedures you are doing, which personal protective equipment is most likely necessary. So if you think now about back to business, back to surgery, we have to consider also what type of surgery we need. Are we talking about the patient who has an infected wisdom tooth and the patient is in a lot of pain and can really not wait any longer? Or are we talking about more elective procedures such as implant placement or sinus lift procedure? Or are we talking about surgical procedures where we can actually avoid completely the aerosol protection, like mucogingival surgery? And then, how can we minimize the risk during those surgeries if we decide to do them and if we book the patients for them? How can we minimize the risk for us, for our team, and for the patients? Let's think about the surgical technique. And let me give you 2 examples. If we think, for example, about bone collection, autologous bone collection, on the very right side of the screen, you see a very nice and charming way with the piezomet to collect easy and without any big effort a autologous bone. But unfortunately, at the moment, it is producing aerosols. So we can maybe consider the 2 options which you see to the left and in the center, where we take a respiratorium or small forceps to collect autologous bone without any aerosol production. Or of course, we can also go to the cupboard and combine it or use only bone substitutes, depending, of course, always on the type of procedure we are planning to and what is the correct indication. Or another example, periodontal surgery. We all love our ultrasonic scalers because it's going nicely, it's going fast, it's going easy without much effort for our fingers. But unfortunately, it is producing aerosols. So maybe for the time being, we should consider to stay more with our hand instruments, which takes a little bit longer, which hurts maybe a little bit more in the fingers, but it avoids the aerosol production. What is another important aspect? Another important aspect is the suction. So we can see here on the left the surgical handpiece and the piezomet without any suction. And now on the right, with the suction in place, and we can see how much the aerosols are reduced. So it is really important to stress our assistant to concentrate on the procedure and to stay focused and to stay as close as possible. Of course, it's not diminishing it completely, but it's reducing it clearly. Then we should stay with the settings of each device here. We shouldn't use now excessively more water, excessively less water. We'll also come back to that shortly. And we should think about the timing. So really do not start the device outside of the mouth, because then it's already spraying in the mouth and maybe from the mouth saliva is already spraying out again. Go in, go where you have to do the procedure, put the suction in place, and then start the device. Regarding the suction, we can also think about which type of suction we should use. So we know, for example, from the prophylaxis that we have quite nice big suctions, which have also, if we take, for example, numbers from Dürr, really a huge efficacy. So they are suctioning 300 liters per minute. However, if you think about surgery, we somehow still stick a little bit with those small suctions, which have less power. So they have about 45 liters per minute. So maybe we should consider to use a second additional suction now during surgery to reduce the aerosol spraying around in the operating room. And illustrated here by taking up salt, you can see the different efficacy of those different suctions. Whether such extraoral suctions are necessary and improving the situation for us, we actually do not know on an evidence-based level. But it makes sense to have an additional big suction close to the mouth, which is simply reducing the aerosols in the operating room. If one looks into PubMed, one can only find a single publication on the usefulness of an extraoral vacuum aspirator. Surprisingly, this publication is already from 2001, so long before the COVID-19 pandemic. However, the device which they were using looked a little bit more, let's say, old-fashioned. But it indicated that it significantly reduced the contamination in the operating room. So it might be a good idea, but we simply do not have the scientific data for that yet, and especially not which type and which provider is the best, because there are also many different ones on the market. I was talking before about the settings, and because one could get the idea either to reduce the water of the device, to have less aerosol production, or to say, let's increase the water of the device to dilute the saliva as much as possible. So if you think about that, we could, for example, with the piezomet up to 70 milliliters per minute, of the implant med up to 100 milliliters per minute. If you think then about the amount of saliva, the stimulated saliva is maximum 2 milliliters per minute. So theoretically, that would be dilution up to 200 times. But I have put here on purpose now a question mark and on purpose said theoretically, because the aerosol production is not mixed like a cocktail, and it is not functioning like that. So it is always a little bit, if one is working in the mouth, sometimes a bigger amount of saliva is included in the aerosols, a big amount of the virus might be included in the aerosols, so we cannot really make this calculation. And to give you an idea about how much of this virus might be actually in this saliva, I would like to show you a very nice publication. And they have tested the virus load in the saliva. So I would like to concentrate now on the blue circles which represent the values in the saliva. And there one can see that within the first week after the symptoms onset, we had the highest load of the virus in the saliva. Of course, those people we actually should not get into our office. So those people we should catch with the triage and ask them for the symptoms. So if they have symptoms, we should definitely rebook their appointment. But, and that is now kind of interesting, the virus was detected in the saliva up to 25 days after the symptom onset. So almost a month afterwards. And the mean virus load was almost 160 copies per milliliter saliva. Talking about minimizing the risk for the team, we should also consider how can we minimize the risk for our patients. And there we have really to be careful in patient selection. We should follow the guidelines of the WHO, which is clearly indicating that older adults and people with underlying health conditions are at higher risk of developing severe forms of COVID-19. And those underlying health conditions might be diabetes, high blood pressure, heart or lung disease. Let me show you another publication from Italy on this topic, which is underlining the statement of the WHO. And they have assessed the case fatality rate per age and per underlying underlying health symptoms. So we can see here that up to the age of 60, the case fatality rate is actually quite low and stays below 1%. From 60 to 70, it's increasing and to about 3%. And then everything above 70, it's clearly increasing with up to 20% in the above 90 years old. So age is a big factor in for this disease and for the severity of disease and for the case fatality rate. How is it now about the underlying diseases? Of those patients which died from the COVID-19, 3 out of 4 have hypertension, about every third has diabetes. Many of them have any type of cardiovascular disease. So all of them had some additional health issue. And now that is important again for us, that one important, let's say, take-home message. The higher the number of comorbidities, the higher was the risk of dying from a COVID-19 pandemic. So that we should clearly keep in mind if we book and schedule our patients. And another important factor. We know how much, or we have heard a lot, how much the virus is affecting the lungs. So we can imagine that smoking might not be the best combination with COVID-19. And that was also impressively shown by a systematic review. And they assessed the prevalent severity and mortality associated with chronic obstructive pulmonary disease and smoking in patients with COVID-19. And they have collected the data out of 15 studies on approximately 2,500 COVID-19 patients. And there one could clearly see that COPD patients and smokers had a significantly higher risk for a more severe form of the disease. So for the COPD patients, the risk was almost double, and for the smokers, it was increased by 50%. So another factor which we can consider when we think about booking or not booking a patient. And finally, what should we do with our instruments after we have used them? There I can only recommend you to stay with the recommendations of the provider and of the company which you are using. but it is definitely of advantage if one can take the device in many small parts, which of course improves the disinfection. And you can also have a look on the Dentists United homepage, where you also find quite useful information on that topic. Now to the next point, why we can't skip the cooling during surgery. I think during surgery and drilling in bone, we all know why we shouldn't skip the cooling during surgery, but I just would like to bring it back up in our minds. If we increase the temperature due to the lack of cooling to 42-45 degrees in the bone tissue, we produce a reversible heat shock. However, if we keep the temperature for at least 1 minute on 47 degrees, the bone suffers irreversible thermal damage. And if we really manage to heat it up above 70 degrees, we cause immediate bone cell death. And that is something what we definitely do not want when placing an implant. We do not want to be the bone surrounding the implant, which is supposed to or is responsible for the osseointegration, gets such a thermal damage. Of course, there are many other things which affect the heat production during bone surgery. That's like the bone quality or the drilling speed or the pressure which we are applying. But the irrigation is considered as one of the most important variables and should always be used to keep the bone temperature below the critical value. And with that, I come to the last topic. How long can we now wait with the surgery? How long can we wait, for example, after a lateral ridge augmentation, to keep the width which is required for a dental implant installation? Or how long can we wait after the sinus lift procedure and to keep the height for placing the implant? Let's start with the sinus lift procedures, and let me show you a very nice systematic review from a colleague who has also been working shortly in Malmö. They have collected and reviewed the literature on the 3T time-dependent graft volume changes after sinus augmentation. They found 7 controlled and 5 uncontrolled studies, so altogether about 230 sinus lifts, with a range in the follow-up from 6 months to 6 years. And what could one see now? If we look now at this graphic, we see to the left the autogenous bone, then the allografts, then the bone substitutes, and then composite material. Composite material means, for example, a mixture of autogenous bone and bone substitutes. And what we can clearly see here is that autogenous bone suffered clearly a higher reduction of the volume compared, for example, to bone substitutes or to a composite mixture. And additionally, it presented a huge range compared to the other materials. So it might not be the same for every patient, but we cannot really predict in which patient it will be like that. So that is something what one should consider, depending on which material you are using for your sinus lift procedures. It might depend how urgent it is to get the patient in to place the implant. Those were now the results for the controlled studies, but they look quite similar if one is combining the controlled and the uncontrolled studies. So the authors concluded that sinus augmentation with most biomaterials is followed by significant volume reduction. However, we are lacking a little bit, so most of the studies had a shorter follow-up time, so we are lacking a little bit really the long-term data. And as I said, most important and also a take-home message, solely autogenous bone is associated with a considerable volume reduction. On average, approximately 45%. And it is much more unpredictable than, for example, bone substitutes, which suffer approximately only about 20% of volume reduction. And let me show you on this topic a second study, a preclinical study. And it was a radiographic study in mini pigs. And they wanted to assess in a preclinical or in an experimental setting the volumetric changes of the graft after maxillary sinus floor augmentation with bios and autogenous bone. So they made 5 different groups with either only autogenous bone or then always less autogenous bone and increasing amount of bios until the fifth group with only bios. And this confirmed what I have shown you before from the systematic review. We have now on the far left the autogenous bone group only, and on the far right the bios group only. And you can see clearly that the volume reduction was clearly higher in the autogenous bone group only compared to the bios group, and it was going down the less autogenous bone was used. And that was in this study now independent whether the bone was taken from the iliac bone or from the mandibular bone. How about now lateral ridge augmentation? Also a systematic review on this topic and about the fate of the lateral ridge augmentation. And they tried to summarize the literature on the stability of the bone grafting material and of the gained width after lateral ridge augmentation, based on 15 randomized controlled clinical trials. They primarily focused on the block augmentation and on TBR technique. You can see here, for example, directly postoperative, the increase of the alveolar width and how much was lost over time until implant installation, and that appeared a bit higher in the TBR group. But what was interesting, again, what is now relevant for us, for the TBR, it depends again what type of material has been used. So for example, only autogenous bone or only allogenic bone or xenogenic bone was associated with an inferior bone gain compared to a mixture, autogenous bone and xenogenic bone. And then again, maybe the composition has an effect of autogenous bone and xenogenic bone, as we have seen it for the sinus lift. Let me show you here now the last study. That was a randomized controlled clinical trial, and they evaluated the volumetric changes after TBR with two different compositions of deproteinized bovine bone and autogenous bone. They had 13 patients in a split mouth design and followed the patients up to 7.5 months. And they used either a composition of deproteinized bovine bone and autogenous bone of 60:40 or 90:10. Let me show you now the results. We can see here on the left, in the first line, you see the results for the 90:10 mixture, and in the second line for the 60:40. The gain width after 7.5 months was a little bit bigger for the mixture with more autogenous bone, and also the reduction within those 7.5 months was smaller for the mixture with more autogenous bone. So also it depends here a little bit how are we performing our procedures and how stable the result stays over time and how long we can wait now to book our patients. So with that, I'm now at the end of the webinar, and if I would like to give you now a short summary, I would say the most important thing is to find a balance between the risk for the patients, the patient needs, the risk for the team, the economy, and we could add this list up now quite long and quite for a while, but we have to find somehow a balance depending on where we are working, how is the current situation in this country, how is the risk for the patient, is it a risk patient, how important it is that a specific procedure is done right now at the moment in this patient, and so on. So it is quite an individual decision, which is depending on a lot of different factors. With that, I would like to thank you for your kind attention, and I would like to thank WH for organizing this webinar. Once again, I'm sorry for the short delay in the beginning, but I think at least the internet connection was now quite stable. And yeah, you're welcome now to post some questions in the YouTube chat, and I gladly answer them. Otherwise, you also have here my email address if there pop up any questions afterwards. And yeah, just start asking. And maybe until some questions come in the chat, I can maybe show you once more the two previous webinars from Christian Stempf and Georg Gassmann, And you can see, if you like now this webinar, maybe you want to see them, you can see a recording of them on YouTube. And let me also show you maybe some upcoming events. Hopefully not online, hopefully we can meet each other again. For example, if you are from Austria, we have the annual meeting of the Austrian Society of Periodontology, which was postponed now from June to December. And we have also a workshop with WH there, and it is for dental hygienists and prophylaxis assistants. And we primarily want to address the NIVOP concept, so no implantology without periodontology. And we will primarily focus on the time after implant installation, so on the supportive treatment. Or if you're really keen on improving your surgical skills and make a course on that, I can recommend you a course at the Anatomy Institute in Vienna, which will be on the 16th of April next year. It is also supported tremendously by WH, because we're going to have piezomat for every participant, implant mat for every participant. So you really get the option to try all different ways of making, for example, the lateral window for the sinus lift. And it's on fresh cadavers. So the situation is really like in real life with our patients. So it's a good possibility to practice. And so, and then here you have a list of the links and references which have been used for this webinar, if you're interested in it. So let's see whether there have been any questions so far. We can see we had some visitors from Denmark and from the Philippines. So one question is, I want to be orthodontic expert. I think orthodontics is always a good decision. So I wouldn't recommend you something else. I definitely wouldn't recommend you to change it now only due to the COVID-19 pandemic. I would stay with that. Maybe until there come some more questions, I can pick up a little bit the topics which have been asked last time. So one question which I think was posted several times is whether it makes a difference whether we use now the implant mat or whether we use handpiece and so on, whether it makes a difference in the aerosol protection. You have seen the videos which I have shown. So of course, the turbine and also the prophylaxis, so the ultrasonic scalers, are supposed to be those which produce most aerosols. While, for example, the implant mat, which is working on with a lower speed and is producing more bigger droplets which are not flying so far, might be less of an issue. But of course, all of them are producing aerosols, and it depends also a lot on how we are using them. So how much water do we add, how fast are we using them, how good is our assistant with the suctioning, which type of suctioning we are using. And another question was whether it makes sense now it popped up here a question. Patients with COVID-19 influence bone regeneration without autologous bone. I wouldn't have seen any publication on that. So I wouldn't have seen that patients who had been tested positive for COVID-19 would have any problem with bone regeneration afterwards. I wouldn't see now why that should be a case, but I also think if that is the case, it is too early to find right now the data on PubMed on that. And so, as I said, up to now I have not read anything on that, but if it would be the case, I guess we would get to know that earliest in a couple of months, but I wouldn't see now a biologic mechanism which could be behind that, because what one hears most often is that there might be some longer damages of the lung tissue, but otherwise one have not heard something on temporary or even permanent issues after a COVID-19 infection. So then there was now a question about the sinus lift course and how it's going to be with the COVID-19 pandemic. We had planned this course actually this year in March, and we had to cancel it due to the COVID-19 pandemic because it was exactly the weekend when in Europe everyone started to close down. Of course, we will take the precautions which are necessary, so you will be provided with a cone, you will be provided with a mask. You can bring whatever additional personal protective equipment you want to, but of course there will be some aerosol protection. But then on the other hand, we are working with fresh frozen cadavers, so they have been frozen. So I think except for meeting other participants, the risk is relatively small and the rooms are relatively big, so one can stay in a good distance from each other. So I think that shouldn't be an issue. Then there was a question whether I have a setup, how aerosol can be controlled or reduced. Let me go back here quickly, then I can show you maybe once more. Where was it? Here. I mean, we have discussed a little bit what one could do. So we see here, as I said, on the left side, if you use no suction, of course you have the highest aerosol protection. And we see that the suction is producing it relatively a lot. And I think, as I also said, during surgery, consider to use a second suctioner, which you can put somewhere on the side, or maybe consider to take bigger suctions than these regular standards small canules which are used for surgery regularly. And then, as I said, really push your assistant, stay focused, try to be as close as possible, try to make a good timing with her, so you go to the spot where you have to do your procedure, she should be there with the suction, and then start it. Regarding the amount of water, as I said, I would stay with the regular settings and would not go up or down with the water, because if you go down with the water you risk an overheating of the bone, and if you go up it might not be actually that advantageous. So I would stay with the regular settings. Okay. See whether there are any more questions. No. What, for example, was also a topic which was discussed last time was whether we should add any disinfecting solutions to our devices. And there I clearly have to say, please stay with the recommendations of the company, because it might also harm your device. So it depends, for example, for the ultrasonic scalers, it is partly possible to combine the water with the disinfecting solutions, but then it becomes relatively thin what is actually possible. So there, really please see what the company, what you are using, is recommending for your device. Okay, I can once more maybe go back to the last slide, if someone wants to see that. And yeah, otherwise, as I said before, if you would have any questions, you can drop me an email, or you can send an email to WH and they can forward it to me. And then you would be actually at the end of this webinar. And yeah, I hope that you will still have a nice summer, even if we are suffering some limitations in our social life and in the possibilities to travel. But I also think that the summer at home can be a nice change from the last years. So I wish you all the best. Have a